Please take your seats. The next panel will begin now. We will introduce Kristen Higgins, Chief Clinical Officer, City of Hope Cancer Center, Atlanta. Loretta Herhunsi, Thoracic Surgeon, City of Hope. Rick Kittles, Inaugural Senior Vice President of Research, Morehouse School of Medicine. And Lisa Richardson, Director, Division of Cancer Prevention and Control, Centers for Disease Control and Prevention.
Thank you, everyone, for joining us for this next panel, Bridging the Gap, Addressing Cancer Care Disparities. I'm Dr. Kristen Higgins, a radiation oncologist and a lung cancer specialist with expertise in clinical trials, and a professor of radiation oncology at City of Hope National Medical Center. I'm also the Chief Clinical Officer at City of Hope, Atlanta. Just a brief word about City of Hope. City of Hope is a top 5 cancer center that originated in Southern California, but now has a national cancer footprint in Phoenix, Atlanta, and Chicago. I'm very excited to welcome our panelists today, all of which have an expertise in cancer disparities. I will ask each panelist to introduce themselves, give us a brief background about their role, their organization, as well as their research. Dr. Arunse?
Hi, good morning. Thank you so much, Dr. Higgins. And it's such a pleasure to be here with you guys. My name is Loretta Irunse. I am Associate Professor of Surgery at City of Hope in Southern California, Duarte. I'm also a health equity researcher, so I'm a thoracic surgeon who cares for patients with lung cancer, and I also think about how adverse neighborhood social determinants influence outcomes. And so I'm very excited to be talking with our esteemed panelists today.
Hi, I'm Lisa Richardson. I'm the Division Director of Cancer Control at the CDC. I've been there for 25 years now. It's hard to believe. I don't look that old, I know. Anyway, I think as far as equity goes, everything we do in public health is equity. And when I say that, it disturbs some people because I don't call it out as something, extra or, special. But really, that's why public health exists, I believe, is to take care of those who need us, as well as to keep everybody here, healthy as well. And so I'm looking forward to sharing what we do at CDC. So thanks for having me.
All right, good morning. My name is Rick Kittles. I am a professor in the Department of Community Health and Preventive Medicine at Morehouse School of Medicine. I'm also Senior Vice President for Research. I'm a genetic epidemiologist by training. I study cancer health equity, cancer disparities, and overall disparities.
Wonderful. Well, here we are at Health Connect South, and the whole purpose of this conference is to join together, build collaborations, and elevate the care that we provide for our patients in the Southeast. And certainly disparities and overcoming disparities is a huge part of that. We can't go at it alone. We have to work together. We have a great group of panelists here today that have so much expertise. But I want to take a step back and just look at where we've come in cancer care. Over the last decade, we have seen such a rapid pace of innovation and drug development. But if these innovations can't reach patients outside of the ivory tower, how much progress are we really making? We have significant disparities to overcome. I want to just set the stage and give us context and really kind of help everybody understand where we're at with cancer care disparities. I'm going to go over some statistics. I have a cheat sheet here. So we know that medically underserved populations experience higher rates of cancer diagnosis and lower rates of survival. For senior adults living in rural areas, they are 70% more likely to die within 1 year of diagnosis than those in urban areas due to a lack of access of cancer care resources. According to the National Census, from 2014 to 2020, cancer patients from all racial and ethnic minority groups had a lower 5-year survival compared to their non-Hispanic white counterparts. For patients with sexual and gender minority, studies show that they experience disparate care across the cancer continuum, from prevention, screening, diagnosis, treatment, palliative care, and so on. And lastly, in terms of clinical trials that test these new therapies, only 4 to 6% of participants are African American and 3 to 6% are Hispanic, despite representing 15% and 13% of all people with cancer, respectively. We have so much work to do to overcome these disparities. But there is some good news. We have made progress over the years. The US cancer mortality rate has declined since 1991, and the disparity in overall cancer deaths between Black and white populations has narrowed from 32% to 11% since the 1990s. Certainly among women in their early 20s, there was a 65% drop in cervical cancer rates from 2012 to 2019 in the wake of the HPV vaccine. So progress has been made, but we have so much more to do. So let's explore what we can do by working together. So I want to just pose this kind of broad question to our panel. When you think about these realities and the current state of cancer disparities and the progress that we've made, what really stands out to you? Dr. Richardson?
I knew that was going to happen. You know how you try to hide in full sight? But anyway. Well, I want to tag along on something that you just said. I mean, I like to think about history because things have not always been the way they are now, and there's lots of lessons that we can learn. So, as I was thinking and developing, how to go out and talk about disparities as part of my job as director, there's, I think David Williams, some of you guys may know his work. I think he's at Harvard now, but he wrote a paper where he looked at mortality differences between African Americans and white Americans, and in the 50s, it was less, not more. So you quote from the 90s, but you're absolutely correct. And then over the last decade or so, the mortality rate has decreased again, but, I'm curious, what were we doing in the 1950s and 60s that's different from today, right? One of the other things, too, is what you said about therapy. One of my biggest concerns is that I'm an oncologist by training as well, so I think someone said earlier, what would an oncologist be doing in public health? But I think I understand what causes the cancer, or I see the cancer, treating the cancer patient, but also knowing there's lots of things that we can do to prevent that from happening and improve quality of life if you have cancer, if you've survived and you're living, or you have, metastatic disease. But I think for me, it's really about making sure we keep people healthy, which is what we do at CDC, we try. And also when you get cancer, to make sure that you get the best care, and if you survive, that you have the best quality of life. And so I think those are the things that we're working on in the disparities arena at CDC.
Great. Dr. Kittles, what stands out to you?
Well, when we think about the mortality rate drop, but we still see the disparity between Black, white in terms of the mortality rates, it says to me that we still have a lot of work to do. And so while we can, get excited about the drop in the mortality rates, we still have to battle and combat the disparity overall. But I think what is going to be helpful, and what has been helpful from what I've seen, is going out into the diverse communities and talking to them about their health. And health education really drives a lot of the increased knowledge and the excitement around screening, around going to the doctor, and being prepared when you go to the doctor, when you present with particular illness. So I think there's still a lot of work that has to be done in terms of going out into the community and having that conversation.
And Dr. Arunse?
Yes, so I totally would agree. I'm usually a half glass full sort of person, so I relish the fact that there's been some progress, but there's no question that we've got significant gaps that remain. And I think what stands out to me is our sort of ability now to sort of frame the importance of structural barriers, structural inequities, understanding that these disparities are not random, they're not by chance, but they're in many ways were intentional, right? Because there are policies and practices that disadvantage some groups while advantaging others. And it's that sort of understanding that will drive us, I think, to equity. We're not going to get there just by siloed initiatives, but taking a step back and thinking more systemically and systematically about it, because that's what caused it in the first place. And so that's why stuff like this is important. I don't believe anymore in just coming and talking. It's like, how do we do things differently? And it really will take all of us stakeholders coming to the table and understanding that it's not just an event, it's not just going out into the community one or even two times, but like, how do we step back and think about things sort of systematically so that we can get these structural barriers and these social determinants that are upstream to no longer disadvantage certain groups? So I think that's what stands out to me now.
Yeah, those are all very good points. Dr. Kittles, I want to delve into clinical trials a little bit more. I gave the statistic that we have poor participation in clinical trials for our minority populations. Certainly the FDA has mandated that pharmaceutical companies increase these minority rates in their trials if they're looking for a new drug approval. But there are some issues when we're trying to talk to minority patients about clinical trials because of history and what's happened. And my question to you is, how can we create trust with our patients when we're discussing clinical trials? What can a clinician do? How can we best approach the idea of research with our patients?
Well, what you're talking about really is building the trust, having the trust with your patient. And a lot of times the patient wants to see themselves in the work, in the research, in the practice. And many times, diverse patients don't see that. There is a lot of work, as I said, that needs to be done in terms of education around clinical trials. But I have seen that once communities are educated, they step up, they get excited, they want to be engaged around these trials. But the barriers still exist. So we have the barrier of lack of trust. We have the barrier of finance. We have the barrier of inconvenience. We have the barrier of fear, right? And so, as Dr. E just mentioned, this is a multi-factorial sort of situation where we have to build upon best practices and working together to solve the problem.
Yeah, and I think it's important to call out, as physicians, we also have biases, and many physicians make assumptions about a patient's interest in a clinical trial and just don't offer a trial if they perhaps perceive that it will be difficult for the patient to participate. So I think it's very important that we look at it from all angles and that we provide training to our clinicians that are presenting these clinical trials to patients so that they understand what the best practices are as well. It really has to be sort of multifactorial. We have to come at it from a lot of different angles. Dr. Richardson?
Yes, so I was on a student's capstone project, and he actually talked to us yesterday at CDC on this very topic. And what he did was to help the people at Oregon State Health University. They wanted to increase the clinical trial enrollment of African Americans. And what he did, basically, it was amazing what you were saying. He embedded himself in the community with the staff from the university and got, the enrollment in the trial from 0.5% to 3%, over like 4 or 5 months. But to your point, we have to go. And one of the quotes that I remember the most was, you have to keep showing up. You can't just come once. Right? You have to come back.
Right, you have to be present and to build that trust.
Right.
Many times we think we build it, they'll come.
No.
We should go out and engage them where they are.
Yeah, that's a great point. And also, let's talk a moment about our pharmaceutical partners. Certainly, we work with industry partners to bring on clinical trials that produce these novel therapies, and I think it's important that our industry partners are willing to consider sites that are in the community where the patients are at. Maybe they don't have a track record of enrolling hundreds of patients in other studies, but you have to be willing to take that risk and say, I'm going to invest in you.
Right. I don't think it's a risk anymore. We know that model just really doesn't work.
Yeah.
When we think about the NCI designated cancer centers and the work, the stellar work that's being done, but there now is this disconnect with providing those benefits to diverse communities.
Yeah.
The best way to do that is to partner with community hospitals, clinics, FQHCs, and really go and hit the ground and engage because you do get positive outcomes from that.
Can I add? So I totally agree. Right. So we've had a system that has been shown to not work over and over again, and it's time for us now to, I think, really think outside of the box. And I think there's been a lot of discussions around diversity in clinical trials, but we keep trying to do it the same way. And I think, okay, let's just take a pause and a beat. I think there's you mentioned, Dr. Higgins, one, and this isn't that novel, let's make sure that we have a systemic way of asking patients to enroll in trials. We don't even do that right. Like, we literally don't. So, and there's so much data that shows that if you ask minoritized communities about trials, they have the same, if not more, chance of saying yes.
Yes.
But we don't even do that. So before, you know what I mean? So some things we can do. So I think that's one. And number two, we've got to, I think, in a different sort of way, think about like the groups with the greatest burden of disease and make sure the trials actually are supporting them and their lived experience. And so the trials that we do now are, the eligibility criteria are off, right? Like, we can't even get the folks who really need it in the trials. We're not thinking about like how people are living and their social determinants that drive and support where they work and live. And so it's almost as if like we've done the pristine trials that actually aren't even reproducible. And so the focus and movement towards trials that actually look more like what people are experiencing is absolutely key. So one, I think, is ask. Number two is create trials that actually are designed with the people with the greatest burden of disease in mind. And we don't do that, because if you did, then you wouldn't have a lung cancer trial where there was 1% African Americans in it, right? Because African Americans have the highest risk and the highest mortality from it. You would think, okay, well, we need to make sure that we are recruiting, you know what I mean? And I do also think we've got to incentivize it differently. I think both our patients, our providers, and even like pharma might need to be incentivized in a way where diversity in trials is like a thing.
Yeah,
Like,
that's
it's
what I was
required.
going to mention.
Right.
You know,
Yeah.
you just mentioned, the design of the trial. A lot of these trials are industry sponsored, and so they also have to be at the table in this discussion around how do we diversify these trials.
Yeah, so another comment that was made, that the young man did in his research was that the African-American community would say, well, what does this have to do with me anyway? What you just said, is this designed in a way that's going to be helpful to me, that I can actually enroll and participate and benefit? So that's why I thought, what he was doing was, just so amazing. He actually works for a pharmaceutical company, so he's going to be making some changes there as well. But yet, it's difficult.
Yeah, I mean, I think Dr. E just hit it right on the head. We have to get the right people at the table when these trials are being designed, NCI trials, industry-sponsored trials, and also, to Dr. Richardson's point, get the patients involved in how these trials are designed, because many times the patient voice is just not there. We forget about it until the very end, and then we, send out an email looking for a patient advocate, and then it's meaningless. It's not really getting the patient involved. So there's a lot of changes that need to be made that certainly aren't easy. And I think it's going to take a lot of people coming together and demanding that we make these changes at sort of all different levels in all different organizations. But it's something that we can certainly rise to the challenge. And there have been, I think, a lot of improvements made over the last several years with more efforts put forth. And hopefully we'll see that bear fruit in the trials that read out over the next decade.
Right.
Unfortunately, as we look at the life cycle of a clinical trial, they're designed, maybe 5-7 years ago, and we see that data now, and we're probably not going to see the fruits of that effort until, these trials are conducted that are designed in, the last few years. So I think there's still going to be a little bit of time until we start to see what we really want to see, the needle being moved. So let's talk a little bit about prevention, and certainly Dr. Richardson is the expert in prevention on our panel, and we know that in the state of Georgia, we have a lot of problems getting screening and preventative efforts to patients, and it's not just in Georgia, it's across the Southeast. And when we think about this, I think you can think of it at sort of like the low-hanging fruit level, what can organizations do, and then the big picture, bigger ideas that require more investment. And I'd like to hear from you just sort of how you think about what we can do, what institutions can really take home, what can be actionable, how can they really move the needle for these prevention services?
So I'm evolving. I should say I haven't evolved, I'm evolving, but to plug our I'm going to plug our program, shameless advertisement, right? We actually administer the National Breast and Cervical Cancer Early Detection Program, which is active here, and we have 50 states, tribes, territories, DC, and so that program is for strictly uninsured women who are low income. Believe it or not, even with the ACA in those places, and we don't have it here in Georgia yet, there's still millions and millions of women out there who don't have access to care. One of the things that we do in our program, we have, outreach. One of the places we're doing outreach now with a focus just to talk about, what you just asked me is the never screened women for cervical cancer. 70% of those women who get cervical cancer have never been screened or haven't been screened in the last 10 years. So to your point, what is the challenge? Why aren't we reaching those women? There's a lot of misinformation out there. I get asked all the time, what can we do about that? And so as I've evolved over time looking at how do we reach out to communities, so in particular, what my new term is real community engagement, not the we got this thing for you, we want you to try it. But how do you start in the community? So one project we're doing in Jackson, Mississippi is looking at structural racism, and the group that's doing it is Black People Against Tobacco. So it is a project that grew out of the community. It did not come from the university, hey, we got this great thing for you. But they were ready to apply for this research grant when we put it out there, and they're in year 2.5 of 5, and so they're the results are starting. But it's really where everyone is invested, and to the point of buying into where it came from your community, so the buy-in is automatic, right? We don't have to go and say, could you please help us and all that. And again, as it started there, that means they are invested in it continuing and being sustained. So that's where I think we're sort of missing the word, and you said it before, Dr. Kittle, communication. How do we go into communities and really communicate? The more important thing is how do we listen to people? We're forming our next thought as they're talking to us, and we're not listening to them. So that's what I think is the biggest, how we're going to, sort of grab a hold of this and get control of it. We have to listen. When I was seeing patients, they know what's wrong. When they come to the office, they know what's wrong, right? So you just have to ask them, what do you think is wrong? And almost always they're right. And so, that's what we have to do. What do you think is the solution? And then really listen and make it happen.
Where do you think is the best place to engage with these patients that we aren't reaching, specifically within their communities? Is it churches? Is it schools?
I think it's so another one of the things we say a lot is we want to meet people where they are. We don't want to meet people where they are. It's hard work. I'm just going to be honest. I'm busy. You're busy, right? It takes energy to go and invest in it someplace. And so it's sort of one of those things where it's just, you go where the people are, for instance. So here's one, for instance, of something we do. We have a completely digital campaign for young women at risk for breast cancer, women under 40. They're digital, right? Because if they're 40 now, that means they've been doing digital for 25 years, right? So we have a fully digital campaign called Bring Your Brave for women who are high risk under the age of 40. So you just have to go where they are. But you got to listen to see where they are too, though, right?
Yeah, those are really great points. Dr. Arunse, you are a thoracic surgeon, so you come at it from a lung cancer lens, and I know that you are well-funded from the NIH in terms of grant money to look specifically at disparities within lung cancer, and I'd love to hear about your work within City of Hope and how specifically collaborations that may not have been obvious have helped you build your career around disparities.
No, I appreciate that. And I think it goes to what Dr. Richardson was just talking about. I think the first thing that I just want to sort of reiterate is that we have to understand and really appreciate that the community is expert, right? And so I think then the way you partner is different, right? Like when I partner with Dr. Kittles, I'm not, just going to him with all of my thoughts. Like I literally need him to bring his. And I think we don't do that well with communities, and that's part of the reason why these gaps remain. So if I go humbly to a community and ask, hey, what are the gaps that you're interested in? Tell us about your lived experience, then we can really, I think we can move forward. I think also, specifically around lung cancer, we know it's the #1 cancer killer in this country and in the world, actually. But the amount of disparities within lung cancer are so, profound. So across the cancer care continuum, from screening to treatment to outcomes, there are significant disparities. And what we've been able to do, which is really exciting, is, as you mentioned, is really think about how even structural barriers, specifically structural racism, can lead to some of these outcome disparities. And so I want to, for instance, give an example, right? When I was coming up, and I too like to consider myself young, even though sometimes that's not what other people say, but what I kept hearing in training was, oh, African Americans have higher risk and death from lung cancer because Black folks smoke more. Well, that's not true. African Americans do not smoke more. In fact, actually, African Americans smoke less, but still there is this higher risk of lung cancer and higher death rate from lung cancer. And so I started thinking about okay, so what might it be? And it's okay, what's the other disparity? It's where people live, right? People literally live in areas that are more polluted, that are closer, that are more deprived, that are more segregated, but we don't think about how those changes, those environments might influence outcomes. And so what we've been able to do is really try to understand how neighborhoods that are actually that are closer to polluting factories because of redlining, right? Because of practices and policies that allow for it, actually can influence higher and more aggressive biology within lung cancer of certain groups, and higher pollution levels that can increase the risk of these cancers, and lower access to good centers that increases the death rate. And so again, when we're thinking about health inequities, it's not all right to just think, well, they're just not going to be compliant, or it's just individual behaviors. We literally have to think about the whole system and what might be driving these outcomes. And so our work, what we've been able to do, which is really great, is partner with geospatial analysts, right? People who literally look at the geography, right? And then environmental epidemiologists, so people who think about air pollution levels, as well as geneticists and folks who do a lot of ancestry work like Dr. Kittles, and also social epidemiologists. And so just really thinking about more comprehensively, and I think some folks talked about that before, how these different exposures can be leading to the disparities that we see. And I'll end with this and simply say that the reason this is important is because we won't get to equity if we don't, part of the definition of equity is understanding the historic and current sort of atrocities and different injustices that lead to people's poor outcomes. So until we call that out and then address it, we're not going to get to good. And so when you were talking about prevention earlier, right, I love all that the CDC is doing and other groups are doing, but the one way to prevent bad health is to reconstruct and really support neighborhoods, right? That's one way to prevent. If we think about these polluting facilities and say, okay, so what are we going to do about that? How are we going to regulate pollution levels better? So I think that has been one of the things that we've been able to do that we're really excited about.
That's such amazing work that you are doing. You should really be applauded for that. I want to take a step back and think a little bit more about collaboration. I come from academia, and when you think about collaboration in clinical research and clinical trials, a lot of times collaboration is killed because of egos. And, you can't decide who's going to lead the project. And one group says, well, that's not going to benefit me, so we're not going to do that. We're not going to participate. And trying to put egos aside and really, that's what it's going to take to make progress. And I guess I want to hear from Dr. Kittles, what is your view on collaboration? You and your role over research for Morehouse, certainly I'm sure that that's part of what you do is forge these collaborations. So
Force?
what's helped you?
Did you say force?
Forge.
Oh, forge.
Forge.
Yeah, I do force sometimes. I do force at times. But seriously, I mean, we have to understand, this is, what we do is in a nutshell, big science. We're trying to have a big impact in terms of health. And so we can't do that individually. Dr. E just mentioned how, with her phenomenal project, I think it's a phenomenal project. She has investigators from multiple disciplines who are very actively involved and engaged around this. You can't do it yourself. And what I tell my students, I find this all the time. There's two things I tell my students. One is, to be a good scientist, you have to be a good storyteller, right? Mm-hmm. The other, because you have to convince people to, give up money or give up their blood or something, But the other thing I tell them is that you really have to leave your ego at the door, mm-hmm. and be actively engaging with folks who have similar goals, but they may have different skill sets. Right. And you guys work together on that to achieve those goals. So I see this as a challenge for academia. Historically, it's been a challenge. But it's one in which, when you see it work, it is phenomenal. It's like, this is really, the engine, all the pistons are kicking, the spark plugs are firing, and things are working. But folks have to realize that this is bigger than you. Yeah. When you wake up in the morning and you go to your job, you want to have an impact. Mm-hmm. And so you have to realize this is bigger than you. Mm-hmm. And operate in that fashion. So let me give you a brief example. So I left California 2 years ago and came here to Atlanta, which isn't foreign to me. I'm from the East Coast. And I studied prostate cancer genetics. And in every city I've been to, I've been various cities, I've always seen that there is a subpopulation of African American men who are underserved in the context around screening for prostate cancer, PSA screening. This is pre the U.S. Preventive Task Force recommendations to downgrade the screening, and post, even today. So I get here 2 years ago, this glorious city of Atlanta, and I look around and I see that black men are not being screened for prostate cancer. And there was a need. And so my team and others, we worked with folks from Grady, Emory, Piedmont. We started screening in the Atlanta community. So much so that in 3 years, in 2 years, we've screened over 3,000 men collectively. What's shocking is that the average age is about 62 years of age, and about 45% of these men have never been screened for prostate cancer. That's what I mean by this subpopulation, this underbelly that nobody touches, nobody engages, nobody follows up on. And so we've had to set up systems where that care could be delivered, because some of these men are underinsured or uninsured. Some of them are scared. Some of them need navigation. Some of them need support when they engage their physician. Mm-hmm. And so then now we are going into the rural communities in the South. Albany, I think you call it Albany. I'm from New York, so I say Albany. I get yelled at all the time, but it's Albany. We're down there now in the rural communities, and who we're working with in those communities are churches. Yeah. Mm-hmm. Mm-hmm. The churches in those communities are very, they have a very strong foothold, and that's where a lot of people are when we meet them. And so we're working with the churches, and we're working with the hospital and primary care groups out there. What I love about Morehouse School of Medicine, if I can brag a little bit,
Please do.
is that the learners, our students, when they graduate,
They go out.
they go out into the community. They're from the community, actually.
Yep.
Large proportion of our students are from the state of Georgia. Various communities, not just the cities, but the rural communities. And they go back. And so we have these primary care networks that are emerging that are going to allow us to do some really cool stuff. Not just screening and prevention, but the other side too, when we talk about trials and what we haven't reached yet in the discussion, precision medicine. Because I think that is where the action is going to be in terms of helping to eliminate some of these disparities. Precision medicine.
Absolutely. Dr. Kittles is very well known in that field, and we'd love to have just a quick tidbit of your work if you want to just elaborate.
My work.
Yes.
Oh.
Around precision medicine.
Oh, around precision medicine. So currently what we're working on, so I mentioned the screening that we're doing in the city of Atlanta and in the rural South. We call that PCP3, Prostate Cancer Precision Prevention Program. Prostate Cancer Precision Prevention Program. So part of it is going out giving free screening in the community to Black, Hispanic, underserved communities. But the other part is research, which is geared around developing biomarkers to improve the PSA screening, but also be able to predict lethal disease. We call those polygenic risk scores in genetic terms. But develop a product, a test that could be used that could inform men of their risk for prostate cancer and if it will be aggressive. So that's the focus of what we're working on now.
Thank you for that. Dr. Richardson, just could you briefly tell us how the CDC approaches collaboration?
So we at CDC can't do anything without all of you. I think our division, there's about 200 of us, which is kind of a large, I didn't realize how large that is, but it's really partnering with providers. Our largest program, for example, the one I talked about, breast and cervical cancer screening, I think at the program level, we work with about 10,000, 15,000 providers in all the communities. They actually work with people, similar to what you just said, where the people are, and they contract from the state health department at that level. And again, like, I didn't know about this meeting before today, but before I came. So I will be back, because there's a lot of people here, that I know. Every room I walk into, there's people that come up and say, "Hey, Dr. Richardson." I'm like, "Oh, wow, I should have been here." So, but for us, it really is about partnering with the state health departments who partner with communities, and it's all about the community work.
Absolutely. And Dr. Arunse, could you just briefly speak about how City of Hope approaches collaboration, whether it's California or nationwide?
Yeah, no, absolutely. I appreciate that. So, again, very excited about all that you guys are doing. And again, it takes all of us. So that's why this conversation around collaboration is so important. I think one thing that I would want to highlight is, I don't know if the news has gotten out over here in Georgia yet, but City of Hope has worked really closely with some different groups in California to pass the California Cancer Bill of Rights. And so I don't know if you guys are familiar with, but in essence, it's a legislation that really came together with like City of Hope, Cedar, and some other institutions, as well as some of our community organizations like the California Black Health Network and others, that really was like, look, first of all, cancer care is different, and we need to make sure that everyone has the right to good cancer care. And so that has been passed by the different bodies and signed by our governor. And the point is that no matter what your insurance is, you have a right to have advanced cancer treatment, as well as the ability for precision medicine and clinical trial opportunities. And I think that's the sort of thing that we couldn't do as an institution and very much need to do. Like, I think, as we're talking, what we've got to do is get our learnings right into communities, as we've been talking about, but we also, I think, need to change the way, like, our policies are structured. And so I see that as an example of how we can, again, come together and move things forward. And so that's one of the examples that we've been able to do. And I think also I think at City of Hope have done a great job in partnering with different organizations and families, and even around fundraising. And we recently, I think it was announced just yesterday, there was $150 million that was given around pancreatic cancer research. There's going to be a new sort of system-wide sort of integration of that as well. And the point of that really is, because pancreatic cancer is so deadly, really making sure that even marginalized, minoritized communities who may suffer from this are supported, and that we do, like, again, out-of-the-box, innovative research that can move us forward. So those are some examples of what we're doing.
Wonderful. Well, I want to thank all of our panelists for participating here today. You all have offered such great, insightful comments. Thank you for taking time out, for joining us. I hope that after this session, we can all come talk to our speakers and communicate and collaborate about, again, how we can move the needle in disparities. This has been a great session. We're going to end 2 minutes early to allow for crosstalk and collaboration. So I want to thank everybody and give the panel a round of applause.